Welcome back. We're talking about the development of the urinary system, and now we are at the clinical correlates of the kidney. This section has been divided into conditions which develop from the developmental anomalies that may occur during the developmental process of the kidney. They can be the conditions like renal agenesis and horseshoe kidney. They can be duplication or multiplication of the kidney, and finally they can be congenital polycystic kidney and lobulated kidney. I hope you're excited to learn the juicy details of this section. Let's move into it and see what happens and how actually it happens. So what is renal agenesis? Agenesis means a kidney does not develop. Since it's renal agenesis is lack of development. Genesis is formation. Agenesis is lack of formation. So renal agenesis means the kidney does not form. So how does that happen? The ureteric bud fails to develop. So the ureteric bud is very important in the formation of kidney because the tip of the ureteric bud is actually covered by the metanephric blastema, and under this linkage or this association between the ureteric bud and the metanephric blastema is very important for the development of the normal kidney. If that does not occur, renal agenesis at that site may take place. So renal agenesis can be unilateral, which means it is on one side, or bilateral, or it can be on both the sides. So one or both the kidneys may be absent in a child, which is known as unilateral or bilateral renal agenesis. So we'll see what unilateral renal agenesis is. It is a relatively common condition. It is more common in males, the cause of which is not known as of yet. It is asymptomatic and compatible with life because the remaining kidney hypertrophies and is responsible for the carrying out of all the excretory functions which both the kidneys were initially supposed to do. So it is detected while carrying out investigations from some other disease. So it is an incidental finding while investigating for some other problem, and the individual usually has a normal life and it does not has any effect on the quality of life of the patient. So bilateral renal agenesis, in this condition both the kidneys have failed to develop. This is incompatible with life. It is relatively uncommon, and the newborn infant may die shortly after birth unless a donor is there for kidney transplant. It also causes oligohydramnios that allows the uterine wall to compress the fetus. So what is oligohydramnios? So amniotic fluid is present within the amniotic cavity that helps to cushion and buffer the fetus from any outside trauma. Oligo means small, so if the amount of amniotic fluid it decreases, this is known as the oligohydramnios, as a result of which the protective effect of this amniotic fluid on the fetus decreases, and the uterine wall can now press on the fetus, causing compression. So this compression of the fetus by the uterine wall can result in the Potter's syndrome. So what is Potter's syndrome? It is deformation of the limbs, the wrinkling of the skin, and an abnormal facial appearance, all of which can be attributed to oligohydramnions causing the compressions on the baby. So moving on, we have duplication or multiplication of the kidneys. So in this condition, we have the presence of one or more kidneys on one or both sides, and it is due to early division of the ureteric bud. So here you can see a double kidney has been formed because the ureteric bud, it underwent early division. This is the division of the ureteric bud. This is one kidney and this is the other kidney, both of which are merged but have different collecting systems. So early division of the ureteric bud may result in formation or duplication of the kidney on one or both the sides. So congenital polycystic kidneys. So as the name suggests, there are multiple large cysts within the kidneys. These cysts actually are full of a urine and can cause obstructive symptoms in the individual. Usually, this disease is accompanied by cysts in liver, in bladder, cysts in pancreas, in other organs of the body as well. It is usually bilateral condition, and the kidney parenchyma is filled with urine-filled vesicles. As you can see in the figure, these are the urine-filled vesicles which are actually being formed within the kidney and are held there. So the embryological basis, there are actually two theories. The excretory and the collecting systems fail to connect with each other. That makes sense actually, that the excretory system and the collecting system, they do not form a connection with each other. As a result, the excretory system is carrying out its function in forming the urine. However, since there is no connection between the excretory system and the collecting system, so this urine that has been formed, it stays in the vesicles within the kidneys, as a result of which the vesicles continue to form and are not being drained. The other explanation, what the scientists give to it is due to abnormal dilation of different parts of the uriniferous tubules, especially in the loop of Henle. So they say there are dilations in the tubules, especially in the loop of Henle, where these dilations are prone to collection of the urine and are responsible for the formation of cystic swellings filled with urine in the kidneys. So the treatment usually includes dialysis and a renal transplant. Moving on, what is a horseshoe kidney? So horseshoe kidney is a kidney that resembles a horseshoe. So when the kidneys are pushed so close together during their passage through the arterial fork, that their lower ends get fused. So in the figure you can see here, while the ascent of kidney was taking place, now if the kidneys are pushed too close to each other, the lower ends of the kidneys might fuse, and this may result in the formation of a large united kidney which resembles a horseshoe, and this is known as a horseshoe shaped kidney. So the inferior poles, these are the inferior poles of the kidney which have been fused during its ascent. The horseshoe kidney gets trapped at the origin of just underneath the origin of the inferior mesenteric artery. So inferior mesenteric artery origin is the site at which the horseshoe kidney is usually trapped. So it usually lies at the level of the lower lumbar vertebrae. So this horseshoe kidney lies at the level of the lower lumbar vertebrae. So the ureters, these are the ureters. They arise from the anterior surface of the kidney and pass in front of the isthmus. This is the isthmus of the kidney, the widened portion, in a caudal direction. So obviously the ureters, which now they arise from the anterior part of the kidney and they come to lie. They pass in front of the isthmus and they move caudally. So lobulated kidney. So initially during development, the kidney is lobulated. However, these lobulations are lost when adult kidney has been formed. If these lobulations persist, this causes the formation of a lobulated kidney. Here you can see this is a lobulated kidney. So persistence of the normal lobulated fetal kidney. The metanephric kidney is lobulated throughout the fetal life. They usually disappear during the first year after birth. If it fails, it may lead to a lobulated kidney. So pelvic kidney. So this is the kidney that is in its normal thoracolumbar position. However, this kidney is in the pelvic region. So a kidney that remains within the pelvic region is known as a pelvic kidney. So it is located in the pelvis. The kidney fails to ascend due to presence of a sickle-shaped fold of peritoneum that usually contains the umbilical artery. It projects from the lateral pelvic wall. So there's a sickle-shaped fold of peritoneum which is projecting from the lateral pelvic wall, from the lateral pelvic wall here somewhere, and this is responsible. It usually contains the umbilical artery and is responsible for the prevention of ascension of kidney. So what is a pancake kidney? So the two kidneys now fuse to form a large mass. Here you can see in the figure a large mass is formed. A large irregular mass has been formed by the fusion of two kidneys, and this mass may lie in the midline or on either sides. And now we have the supernumerary or aberrant renal arteries. So we talked about this earlier. During the ascent of the kidney progressively attains newer blood supply. Initially, the kidney was supplied by the median sacral artery, but as the kidney moves up, various branches from the abdominal aorta continue to supply the artery till it achieves its thoracolumbar position so that the adult renal artery may supply the kidney. However, if these arteries persist, this results in the supernumerary or aberrant renal arteries. So it represents persistence of the fetal arteries. These are the fetal arteries which were supplying the kidney when the kidney was in a lower position. Now these arteries are persisting. These are these persisting arteries. Now the clinical importance. The clinical importance is that they may cross the pelvic-ureteric junction. So the junction of the pelvis, the renal pelvis and the ureter. So these arteries may actually cross it, and they might obstruct the outflow of urine, which may lead to hydronephrosis. So collection of urine within the renal parenchyma, and as a result the kidney enlarges in size. So this is the clinical importance. So this was all about the clinical correlates of the developmental anomalies of the kidney. We saw how various developmental anomalies may act and how they may present, and what are the management of the patients with these conditions. I hope you understood it. For further sections, keep watching sqadia.com.